Hi everyone, my name is Laursen and I'm an Associate Professor in Gastroenterology from Odense University Hospital in Denmark. Thank you very much for the invitation to do this video abstract. The present study is entitled ABC Score, a new risk score that accurately predicts mortality in upper and lower gastrointestinal bleeding, an international multi-center study. As you all know, bleeding from the upper or lower GI tract are common causes of admission to hospital. Although quite many risk scores have been developed for the assessment of patients with upper or lower GI bleeding, recent studies have shown that none of the existing scores perform satisfactorily in predicting mortality as an isolated endpoint in these patients. Previous risk scores were developed for the assessment of either upper or lower GI bleeding, despite the fact that it initially may be difficult to discriminate between patients with upper and patients with lower GI bleeding. Therefore, the aim of our study was to develop a pre-endoscopic risk score for prediction of mortality in both patients with upper and patients with lower GI bleeding. Based on a large international multi-center study, including almost 10,000 patients with upper or lower GI bleeding, we developed and validated a new pre-endoscopic risk score based on patients' age, blood tests, and comorbidities, thus named the ABC score. As you see in this table, the ABC score includes patient's age, urea, albumin, and creatinine values at presentation, presence of altered mental status, liver cirrhosis, disseminated malignancy, and American Society of Anesthesiology score. A signed score for each variable is shown in the column to the right. As shown in this graph, we found that the ABC score performed well in predicting 30-day mortality in upper GI bleeding, corresponding to an area under the received operating characteristics curve of 0.81, which was superior to the aim 65. ABC score performed similarly well in predicting in-hospital mortality in lower GI bleeding, corresponding to an area under the received operating characteristics curve of 0.84, which was better than previous scores within this field. The optimal threshold for identifying patients in low risk of death was an ABC score of 3 or less. Using this threshold, ABC score enabled early identification of the 40% of patients with upper GI bleeding and 71% of patients with lower GI bleeding who were at very low risk of death during hospitalization or within 30 days with mortality rates of 1% or less. The best threshold for identifying patients in high risk of death was an ABC score of 8 or more. Using this threshold, ABC score enabled identification of the 15% of patients with upper GI bleeding and 3% of patients with lower GI bleeding who had very high risk of death during hospitalization or within 30 days with mortality rates ranging from 18 to 25%. We believe that implementation of ABC score may help the clinician in early identification of patients with high mortality risk who would need close monitoring and potential targeted management, in addition to identify patients for whom further active treatment may be considered futile. Regarding identification of patients suitable for outpatient management, we still recommend use of the Glasgow-Bradford score, which is superior to ABC score for predicting patients' need for hospital-based intervention. Thank you very much for your kind attention.